but we'll just go further into the next set of ideas that we really wanted to discuss. So can I request Anurag to really come in, who's going to be chairing the session. We have 3 more people who are joining us. We have Nikolai Gilbert. Nikolai, yes, I can see him. Welcome, and thanks a lot for acceding to our request. Why don't you just join us here? And Neeraj, thanks a lot for enabling to get him to really speak here. We have Stephen Ezell. Stephen, thank you. He's come all the way from DC. And we have Seema Handu, please. So could you please be on stage? Anurag, you have exactly 60 minutes to take care of the session.
Thank you, Amit. Lovely to be here. Welcome to Stanford campus. Over the next 60 minutes, we'll talk about healthcare in India. And in many ways, healthcare in India is a proxy for healthcare around the world. India represents first world healthcare ecosystem in certain parts, middle income healthcare ecosystem, and then you also have underserved global health, as it's euphemistically called. So I'm just going to go through very quickly some of the slides just to set the conversation. There you go. There are 2 parts to my comments very quickly to set the context. Why do we need healthcare innovation in India? And what role does biodesign, the program that I'm part of here at Stanford, what has it played? Because it also represents the kinds of things that we may want to do in India. We all know this economic growth story. It's passing multiple countries along the way to becoming the 3rd largest economy by end of the decade and 2nd largest by 2047. And it's on the back of this demographic. But that demographic is not a given. The age is given, but the ability of that demographic to deliver growth is not a given. And a big part of it depends on how healthy the nation is. There are some estimates that 2% of growth per year would be compromised if the society is not healthy. That translates to $2 trillion in cumulative impact by 2030 alone. And the disease burden that you see on the right, for the longest time, infectious diseases was the biggest challenge for India and other LMIC nations. Lifestyle diseases, chronic diseases, non-communicable diseases, no matter how you call it, are actually becoming really, really significant burden. And they're becoming burden not only in the big cities like Delhi and Mumbai and Bangalore, they're also becoming big problems for lower tier cities and rural areas, which are the future engines of growth. Without their growth of those parts of India, India's economic growth is not guaranteed. So, you would wonder, well, how do we deal with it? India has traditionally invested precious little in healthcare. There are other priorities, hunger, poverty overall, education, a lot of other priorities. Health was a priority, but it came amongst a dozen other priorities. And yet, government has been able to increase its spend over the last decade. It's now up to 50% of total expenditure of the country actually is government's expenditure. Most of it used to be out of pocket. When I was growing up in India, it used to be out of pocket mostly. But that's not enough because it's actually, we feel India lags quite far behind most of the major economies in the world. It's considered that 10% is supposed to be a good spend, 10% of GDP on healthcare is supposed to be a good spend. US, we do badly on that. We need 20%. I don't know why we need to spend 20%, but 10% is considered to be a good spend, and India spends only 4.5% total, including the government spend and the private sector out-of-pocket spend. So India is quite far behind on that. The question is, what does India need to do to sort of address the disease burden that's coming and the risks that it has to its economy, socio-economic progress? I would argue, and COVID has actually enhanced or accelerated this particular view, it needs to go from sick care to healthcare to health and wellness. Let me explain. Think of a healthcare system the way we have it here in India, everywhere, as a sick care system, as a double-walled edifice where you only engage with that system when you fall sick. You don't go to an institution, a clinic, or to a doctor if you're healthy. And once you have been treated for your condition, you are thrown out of that sick care system and you no longer have access to that. We need to actually move to healthcare system where we are focusing on overall health of the people, of the communities, of the society. And ultimately, we need to get to health and wellness, which also means preventative health and other names that you can call it. Society being healthy, physically, mentally, is where we need to go. And hopefully we'll talk about that in our session today. The gap that we see in terms of investment in that shift from sick care to health and wellness is estimated to be $200 billion per year. That's a substantial investment. Even a country that's economically growing as fast as India is, it can't really afford to increase that. This is where innovation comes into play, the technology innovation. We just heard from Mr. Kant this tremendous progress that India has made in creating this India stack. Today, I will not talk as much about digital health because that's a completely entire day's session worth on its own. But I'll tell you, that's a big part of India's future. That's a big part of global health's future, which is an area of my work. Stanford by Design, my program, I'm switching now, basically uses design thinking to train health technology innovators in coming up with health technology innovations rooted in the needs, unmet needs. So the simple rule here is, just as in design thinking, start with the problem first. Don't start with the solution. One of the biggest challenges that we have in complex problems like healthcare and social challenges is that we think we know what the problem is, then we rush to solutions. And what we teach is that start with the unmet need first. And we've been doing this in India for 15 years now, 16 years actually. This is the 16th year. We started in 2007 with Government of India, with AIIMS and IIT Delhi. We started training fellows that came to Stanford, and they went back and they did the work in India, created an ecosystem around them. These amazing health technology innovators created a bunch of technologies. And it actually led to a bunch of other programs, and I'll talk in a minute about that. But we realized that many of these innovators are actually struggling to bring their technologies to communities that needed them. So we created what is called Founders Forum, where we started to advise them and help them translate their solution. That led to another program called Innovators Garage, which is earlier in the value chain. And then we realized that policy is really, really critical. Policy actually makes major movement in the impact, in healthcare system impact. So last few years, we've been engaging with the Government of India and state governments quite actively, and that has led to some very tangible results. Here are some outcomes that from our work over the last 16 years. There are already 20 plus medtech innovation programs across India, 20 plus programs of the kind that we have here at Stanford, 1,000 plus innovators. This is a powerful force for change in Indian healthcare system. $1 billion plus has been invested by Government of India. I'm not even talking about private sector investment, venture capital investment. Government has invested about $1 billion cumulatively during this period. And you have folks that are saying this has really been an impactful thing. Here's some examples of technologies that came out of our programs. This is a neonatal hearing screening technology, which is designed in India by an Indian innovator for India's unmet needs. This is a first innovation in 50 years in neonatal resuscitation, again by an Indian innovator for India's needs. It's actually gone global. It's serving a lot of LMIC countries now. This is an ophthalmological device plus AI solution that now is serving entire populations of states, bringing ophthalmological screening and care to entire populations. TriCog is something that focuses on heart disease. And this basically is a device plus a digital health solution for screening of patients being done across 4 states now and rapidly growing. All of these technologies that have been developed, and there are other examples galore. I have at least 60, 70 other examples, which I'm not going to go through. But the point I want to make on this slide is that COVID has accelerated this move towards health technology innovation. India needed a lot of innovation during COVID-19, and healthcare investors actually realized that India has this capacity. In 2020, they had invested $316 billion. By 2021, they had invested $2+ billion in 100+ startups. So private sector is moving in, venture capital is moving in. These are examples of technologies that were born in India for India's needs during COVID. The third largest supplier of swabs for diagnostic tests, for COVID tests in India came about in a matter of 3 weeks during the early part of COVID. That's the pace at which innovation moved in India. Problem is that although there are lots of innovators, 1,000 plus, and there are lots of technologies that are being developed, 90% of these are dealing with challenges related to scale. How do you get to these technologies from a couple of million people to tens of millions, to hundreds of millions, to a billion plus population? And that's the biggest challenge. And I'm not going to go through this list. This list comes from the needs that have been identified by our innovators. Our innovators who work with us have told us these are the gaps. It's a long list. But you'll see some common themes there, and they're addressable, actually. And we indeed, our work with Government of India through PMJ program, Ayushman Bharat program, has led to a wonderful program called Market Access Program, which is working with the lowest hanging fruits in these technologies, helping them sort of translate into a marketplace. It's a remarkable program, and we are advising that program. I'm not going to go through all the slides. I just want to point to the thing on the right. We have a Path and Social Alpha in the room. They are partners. They basically led this primary healthcare technology challenge. We are in the second year of that. That has identified a bunch of primary healthcare technologies, shifting the task of healthcare intervention closer to home, closer to community, which is what sick care needs to go towards, sick care to health and wellness within your communities, within your own homes. There are a few other things that are needed, and I'll just quickly go through it. I'm not going to spend too much time on it. Number one, we are an educational institution, and we focus on training. India needs a continent-sized training program for bringing innovative mindset across the value chain, from a patient care pathway at patient starting at home all the way to tertiary care system and back. We need innovative mindset across the healthcare system. Anybody who engages with the healthcare system, doctors, engineers, IT professionals, procurement folks, finance folks, government officials, everybody should learn this mindset, needs-driven innovation that responds to the needs on the ground. There needs to be a policy framework. Health is a state subject in India. A lot of these technologies that are developed are supported by national organizations, but when they go to states, each state deals with it differently. Procurement is really challenging. A lot of this is very risk-averse procurement processes. You can't do 3 bids if your technology is innovative. It's the only one of its kind. You can't do three bids for that, 3 different solution providers. So there needs to be, at every stage of technology development and implementation, there needs to be a policy framework. And we've been advising in Government of India and various state governments on this. And this is the last part. This itself can be a really substantial thing. I had a whole economic analysis, financial analysis done on this. This could become a $1 trillion industry for India. India could do with medical devices and health technologies, including digital health, what it did with vaccines. In vaccines, India provides 60% of world supply, world's needs. You could actually do in India the same thing with health technologies. So I'm going to end with this, and I'm going to invite our panelists to share their thoughts, and then we'll get into a conversation. Unless we should do some questions now, Amit, or should we just wait for the panelists to finish first? Yeah, okay. So let me invite Stephen.
I'm Stephen Nizel. I'm the Vice President of Global Innovation Policy at a Washington, D.C.-based think tank called the Information Technology and Innovation Foundation, and have 2 parts of my slides today. The first, looking broadly at the state of global biomedical innovation, and secondly, applying some of that to India. So we really are in a golden age of biotechnological innovation today. Currently, there are at least 8,000 new medicines under development globally, at least 75% of those first in class to treat a disease, close to 850 for cancers, many for rare, tropical, and neglected diseases, and starting to tackle challenges like neurological and autoimmune diseases, mental health disorders. It's very difficult, though. Of the last 146 drugs to go to clinical trial for the treatment of Alzheimer's, only 4 succeeded. That's a 97% failure rate. So pushing the boundaries of biomedical innovation forward is going to be very hard, but can produce tremendous benefits for society. But as Anurag said, that's good, because across both the developed and developing countries alike, we're increasingly facing commonly shared challenges. Non-communicable diseases like cardiovascular disease, cancer, and diabetes actually account for 77% of fatalities in developing countries now. And in fact, developing nations bear 80% of the global cardiovascular disease death burden. India's rate is actually 1.6 times that of the United States. It's somewhat different in cancer, where it's much worse in the United States. By 2050, at least 1 in 2 Americans will receive a cancer diagnosis in their lifetime. In India, the rate is 1 in 10 citizens today. But managing the economic challenges presented by chronic conditions like diabetes and heart disease will be very important. In India, 62% of the total disease burden is attributable to chronic diseases. Fortunately, we're really starting to develop innovative platforms to drive biomedical technology solutions. If you're familiar with gene editing through tools like CRISPR-Cas, it really offers profound opportunities to innovate. Editas Bioscience in Boston has tackled childhood leukemia. Like leukemia is a missequencing of your DNA, their own genome sequences. They've been able to go in with kids and get full remediation of childhood leukemia by fixing the broken DNA strand. Spark Biopharmaceuticals in Pennsylvania has developed a drug called Luxturna, which can actually fix inherited childhood blindness by replacing a defect in the RPE65 gene that causes it. Elsewhere, in cancer, immuno or cell therapy involves treatments manufactured uniquely for each individual patient using a patient's own T cells as a starting material. And I think this is a very cool slide of a CAR T, a chimeric antigen receptor T cell that's attacking a leukemia cell in the patient. Of course, we know about mRNA from the conversation last night. This, of course, carries instructions for cells to make specific proteins and was vital in solving the COVID-19 challenge. But there are currently 520 ongoing clinical trials globally testing mRNA as a delivery vector across more than 20 disease categories. And as the previous speaker mentioned, the advent of artificial intelligence and machine learning is going to truly transform innovation. We wrote a report called The Promise of Data-Driven Drug Development a couple of years back. Some incredible examples. So when we look at ALS, or Lou Gehrig's disease, autoimmune disease, IBM Watson researchers found as many biomarkers in 1 year, and biomarkers being a signal in the body of where the disease may be starting. They found as many in 1 year as researchers had found in the previous 10 using traditional biochemistry techniques. Anybody heard of the company called Grail, based in Menlo Park, just down the road? So Grail and competitors like Thrive are using AI to detect circulating tumor DNA through liquid biopsies. Grail, its multi-cancer early detection system, can detect as many as 50 different types of cancer from a single blood draw in the body, and it can identify the source of the cancerous tissue with 97% accuracy and a false positive rates of less than 1%. If this can really take off, it can move the world from a paradigm of screening for individual cancers to screening individuals for cancer, and be a tremendous breakthrough. A couple of years back, ITIF, in partnership with George Mason University, launched a new project called Innovate for Health. And our goal here is to showcase how developing country innovators are tackling on-the-ground, local, regional, and global health challenges. We have over 60 case studies available online and in that report from 40 countries, really showing how we can unlock the potential of local innovators to solve challenges, and note that intellectual property is a critical enabler of doing so. The studies look at challenges such as adapting healthcare interventions for environments where resources and infrastructure are challenging, developing affordable interventions to meet basic needs in challenging environments, getting healthcare people in places where it's hard to, providing affordable, robust tests for diagnosing diseases, et cetera. Just want to showcase a couple examples. My favorite is this ArcTech passive vaccine cooler, which can actually keep vaccines at a steady, cool temperature for up to 30 days. It can support a village of 6,000 people with needed vaccines, getting into really remote environments. The PEAK portable eye exam kit developed in Kenya brings the optometrist office to the patient, combines an ophthalmoscope and a retina camera, and really has increased access to ophthalmology services. Of course, the Embrace infant warmer was actually developed here at the Stanford Design for Extreme Affordability program, and this creates almost 100% of babies born before 32 weeks survive in high-income countries. It's only half in the developing world because they get hypothermia, and this infant warmer has been incredible to solve the challenge. Just a couple of other India-specific examples. There's one called the AMRIT. It's the arsenic and metal removing by India technology, a portable nanomaterial water filter that can be taken to remote areas. We profile other innovations like Covaxin, an in-pedigree verification system for counterfeit drugs, et cetera. But a nice extension of all the great examples you showed. We talked about digital health. So let me conclude by providing a couple of recommendations for Indian policymakers to drive digital health. I think the first is to really, as you noted, Anurag, recognize the broad economic impact of improved health delivery. India's GDP is decreased by at least 1%, if not more, every year due to the economic impact of heart disease, stroke, and diabetes alone. If you look at the United States, improvements in our life expectancy from 1970 to 1990 added $2.8 trillion to U.S. productivity, equal to $12,000 per citizen. So increasing the share of GDP going to health is critical. Recognize that far from being a driver of healthcare system cost, innovative medicines can actually help solve it. One study in the US found that from 1997 to 2010, the value of reductions in work loss days and hospital admissions attributable to pharmaceutical innovation was 3 times larger than the cost of new drugs consumed. Recognize the importance of digital infrastructure. And 2 things I think are really important for India, both in the life sciences and in your ITC economy. India needs to drop its opposition to the abrogation of the WTO e-commerce customs duty moratorium. If India wants to tap into this rich opportunity to do remote radiological services, looking at x-rays, the notion that you would tax that digital transaction, building semiconductors. If India had the ability to impose duties or tariffs on the movement of designs of semiconductors or the designs of semiconductor fabs, you're simply not going to get any ITC production in India. Also, join the Information Technology Agreement 2. This is a trade agreement that removes tariffs on trade in ICT goods, including a number of medical devices. And lastly, in conclusion, India needs to set a goal of becoming a G20 life sciences innovator. What do I mean by that? It's well and good that India has a robust generics biosimilars industry. But being a member of the OECD or the G20 is not about being a high-income, large economy or a high-income one. It is fundamentally about accepting a responsibility that these nations have to unleash the power of their citizenry to innovate for the benefit of humankind. And that's nowhere more the case than the life sciences sector. So thank you very much.
Nicola?
Yes. Yeah, you can hear me? Can you hear me well? Okay. Well, good morning, everyone. It's a great pleasure to be here. Although I feel with the weather, I would rather be in India right now. It seems like a more warm climate. It's great to be at Stanford. It's actually my first visit here. I'm the CEO of Path. I joined Path 3 years ago, and I am from Copenhagen, Denmark, but I live in a little bit north of here in Seattle. So it's great to be down here at Stanford, and thank you for the invitation and for joining this important discussion. Because India is very much in the limelight right now and the center for a lot of important discussions going on around the world. And you talked about the G20, and I will also come back to that in a moment. My short remarks today is going to be a little bit different and maybe addressing some of the global priorities that we see at Path coming out of the COVID crisis and pandemic. What have we learned, and where do we still have some way to go as a global community to address global health challenges around the world? And then I'm going to speak a little bit about India's role during the pandemic and what we see as lessons learned from that, and then also how India can be an inspirator for other countries from the global south in their desire to also build an industry of pharmaceutical production, probably not at the scale of India, but actually how can other countries learn from India. But starting at the pandemic and coming out of that and the progress that we have made in healthcare over many decades now, we've heard about today and yesterday as well, that if you look at some of the main indicators, maternal mortality, under 5 mortality for children, the world has made great progress on many healthcare outcomes, not only in India, but around the world. Also on the technologies, as my colleague just mentioned here, there's so much going on in terms of innovation, biodesign, Anurag mentioned this as well. So, I mean, the world and technology revolution and mRNA and all this is amazing what's going on, and it helps us address diseases that we didn't think we could address 20 years ago. So it gives us a lot of hope that there is more innovation that can solve challenges that we're all facing in our own lives, and also how do we take care of the world population and its health. But with all those promises that technology and innovation offers, we also have challenges that we have seen with the COVID pandemic with regards to equity, affordability, and access. So the equal access to this information, innovation, information, vaccines, therapeutics, is something we all know we had issues before the pandemic, but now for sure we are daily or have been daily reminded about the distribution of vaccines around the world and the issues on health equity. And not only between countries. Of course, we know that there was hoarding happening in countries of the north, and that led to lack of supply in many global south countries. But we also know that within countries there was a huge equity issue in terms of how do you distribute the scarce resources and supply you have available. So the equity piece, if we talk about the priorities coming out of the COVID, needs to be at the center. And I represent an organization called PATH, which is a global health, public health NGO. We have existed for almost 50 years, and health equity is our mission. We have around 3,000 people around the world, and I'm not from India, but I have 900 colleagues, and Niraj here, sitting here, is our country director and also regional responsible for our India office. So we have a lot of projects in India and have been in the country for many, many years. But we operate, as I said, in 70 countries around the world. Our main work is on the innovation side, as we have discussed this morning. So innovation on vaccines, diagnostics, medical technologies, and also a proud partner with Stanford and Anurag's team. But we also work on technical assistance directly with countries, helping them address pandemics, infectious diseases, as well as non-communicable diseases as well. So it's an organization that works basically across the value chain. So what we have seen and what we have learned through all our interactions in the US, but also in the 70 countries we operate, is that some of the priorities we would like to see also India addressing as the chair of G20 is centered around the equity and the access and affordability. And we are happy to see that that is actually coming into the documentation, coming into the reports that are being drafted on the health agenda for G20. Another topic that we see really critical coming out of COVID is the piece of health systems and health system strengthening. And here we're not just seeing, it's not enough to have the facilities, the buildings, the smart technologies. We need to have the workforce, we need to pay the workforce, and we need to have enough workforce to actually help address the patient's needs. And that workforce, of course, it's very different from country to country in terms of how are they set up. Is it a public system? Is it a private-driven system? And we need to, accept the fact that there are different systems. Some are public and private, but we need them to be integrated and holistically thinking about populations in the countries. So the health systems piece and strengthening that is really, really essential and all its components. We also see very much a need for an end to the vertical thinking in terms of development assistance and global health assistance. So we have had large funding pockets for specific diseases, which are all critical, like malaria, HIV, TB. But there are just so many other diseases that are affecting nations around the world, including India, being infectious diseases, but also, as you mentioned in your presentation, that 80% of the burden, close to 80% of the burden of non-communicable diseases are actually happening in low and middle income countries. So that's a fact. And that fact means that it drains government budgets at a similar scale and probably even more than infectious diseases. And it's hard to prioritize where should investments be made. But if you do invest in the health system, you actually address both the non-communicable and the infectious diseases. We have a huge catching up to do on immunization. So obviously with COVID, there was a lack of desire to go to visit clinics, to get your vaccines. So the immunization agenda needs to catch up again around the world. Otherwise, we are afraid that we're going to see a lot of re-emergence of diseases like polio, measles, and so forth. So that's an important priority also to going forward. Then there is the whole, and this is a very sensitive topic, it's around national security, and of course, in this case, India's national security and every country's national security versus how do we protect the world, the global health security agenda. And that is where the collective response comes in, and how do we get the world players, the big players around the world, to come around the same table to address pandemic preparedness and response, to share information, share data. And there I'm a little bit less optimistic than I am on the innovation side. But there are governments, including India, who is trying to look at the architecture, look at the way we can utilize multilateral organizations like WHO to actually improve the way we work together to address disease burdens and epidemics around the world. It is a collective response, and our common failure, as we had in the pandemic, it cannot be repeated again. So it's important that India, in the G20 chairmanship, that they also continue to drive that agenda forward. And I think Japan did it well on the G7, but now that needs to continue on also beyond India when Brazil takes the chairmanship of G20. If you look at India's priorities for G20, and you probably heard this before, so there is the health emergency piece. It's there, it's central, pandemic preparedness and response. And not only in the human kingdom, but also in the animal kingdom, which is important to know that the zoonotic disease spread from animals to humans are very present. So we are very glad to see that India is bringing the One Health approach into the agenda of G20. Another piece is the strengthening of the supply chains of corporate pharmaceuticals and medical equipment, both on the vaccine side and the therapeutic sides, PPE and so forth. It is a huge issue, and if you speak to African leaders, they will say, and they said there was an African-US summit a couple of months ago in Washington, D.C. that I attended. And there it's very clear that you have the presidents of leading African nations saying, never again are we going to depend on the North for vaccine supplies. Never again we're going to do that. And of course, that is a call to action, and they are taking action on creating an African CDC, strengthening that, the African Union. So there is a desire to strengthen also the capacity of vaccine manufacturing and therapeutics manufacturing in Africa as well. Before this trip, I actually came from South America, and also South America and PAHO, the organization there, is eager to strengthen the supplies for the South American continent. And these discussions are happening all around the world, and they're looking to India for inspiration and sharing technologies, sharing knowledge because we all know it's not enough to just build a factory. There's so much more that goes into that. And PATH, our organization, is working with many of those developing country manufacturers around the world to help them build capacity so that they can become an important part of the global supply chain for either vaccines, therapeutics, or other medical countermeasures. So that agenda is really critical. And there's no better country to actually take that topic on of pharmaceutical supply chain than India, because you've shown the way to actually demonstrate how it can be done and how do you and then engage India's manufacturing into the global system through Gavi and other mechanisms with UNICEF. The last priority that we have seen and on the agenda for G20 is the digital health piece as an enabler, and this is something you talked about as well before. So we see digital as, we're not doing it for the sake of digital. We're doing digital health, telemedicines for the sake of better outcomes, better care, better impact. So digital is not for us a goal in itself. The digital is an enabler for getting information, public health information, in the right hands at the right time so that decision makers can actually address outbreaks in small communities around the world, around in the villages, in their countries. And then also digital can be a way that we can share information at a global level. It ties back a bit to the collective response of sharing information. And that information sharing is not only among countries, but is also within a country, that there is a desire to be transparent about data, outcomes from villages, from cities, and so on, so that decision makers at national level can actually take the necessary actions when they see data that is warnings for epidemics, but also to set the priorities and drive investment decisions. So if we see, as you mentioned, the non-communicable disease burdens on diabetes exploding in an area of a country, of course, there is an obligation for a government to address that with investments, resources, and looking into the issues. And digital information and transparency about information is essential in that journey. Shifting gears 1 second. So if we look at what India really did, I think did really well during the pandemic. The whole of government approach, I think, was something that the Indian government, and we saw, and I was briefed by my colleagues in India, was really early on that it became a national action that India wanted to address the pandemic and learn from the pandemic, because of course it was devastating for all countries to go through this period, and every country was different. India had its own oxygen crisis and the way they responded to it, but also how they learned from it and how they strengthened the supply chain afterwards, and how they have used the pandemic as a catalyst also to improve public health systems, I think is something that other countries could learn from. And of course, I'm coming back to the manufacturing piece. And Niraj, you mentioned to me that there was an issue with getting tests, PCR tests, actually to India at a price point that it was affordable. So the import was at a price point of $25 or something like that. But quickly there was manufacturers in India and innovators that says, well, we can do this better. And we can get it to a price point where that it's not going to drain the budgets, because we rather spend that money on vaccines or other countermeasures, health workforce. So with that innovation, quickly, India was able to produce a PCR test of around $4, which is, of course, very different than $25. So I think no one predicted what could happen with the Delta wave when it hit India, but India learned from it and strengthened the health systems coming out of that. In terms of beyond India, India was also, and we know that the AstraZeneca vaccines was produced at the Serum Institute, and 60% of the global vaccine supply actually for COVID, and also just in beyond COVID, India is the vaccine manufacturer of the world, and so important. And that without that capability, without that willingness to share and to use your production capacity, we would have lost many, many more lives around the world. So I think we owe a huge thank you to the Indian producers, the innovation system, to actually supply the world in a crisis that we all faced. My last point is on India's, again coming back to the G20, but India is very much a voice of the global South and has been for many, many years, and even more so now. Showing the way, inspiring other countries how this can be done, how you can create an innovation ecosystem, how you get public policy to work hand in hand with private innovation, which is really essential because we need the private and the public sector to address the many challenges we're facing. And I think there's very great examples there. What I find every time when I come to India is the huge talent base, a can-do-it attitude, and showing the world how things can get done if you set yourself up for a vision, and it will happen. And you have shown the way. Last comment, so the G20 agenda and the 3 priorities that has been set for the healthcare, it comes with a responsibility, and I think my peer here mentioned that. So those topics that I mentioned, so on health emergencies, strengthening the supply chains of global pharmaceuticals, as well as the digital health, getting the world around and centered around those topics and agree on a common agenda, especially on some of those governance issues, is hard. It's very hard. But India has a lot of diplomatic capability, and I think that with India as the chair, there is a higher likelihood that we are actually going to be able to put equity on the forefront of these priorities and have India shape not only this short time that they are having the candidacy, but actually shape the agenda going forward. If they are willing to share, if they're willing to invest in the world and show that this is the way you did it in India, and this is the way the world can learn, and these are the topics that we need to address collectively as a global community to be better for the next, prepare for the next pandemic. Yeah.
Thank you, Nikolai. Both of you talked about India's responsibility. It's also an opportunity.
Yeah.
And at no other time in the evolution of independent India was India better set up to take that leadership role. And G20 leadership is just an example of it. And this current government has expressed desire, willingness. What you see in Turkey, for example, with earthquake responses is aligned with that. So great points. I'm going to come back to some of those points. Our last but not least panelist is somebody who's subbing for Betty, who had a health issue. And thank you so much, Dr. Seema Handu, for joining in. Happy birthday, by the way. I just saw on Facebook that it's your birthday. You represent an interesting complementary view because you have worked in India. You've been an innovator here. Your thoughts?
Glad to be here. Good morning, everyone. And thank you, Anurag. You heard all about innovation, India, healthcare, and all the digital health. And what I'm going to change slightly a little bit, the topic, and taking it to actually what is going on the ground and how we have been working in India at the primary healthcare facilities and in all possible rural areas also. So I have been working with Pronto International, which is an nonprofit based in Seattle. And I've been managing the India country operations for past 7 years. And I moved to India for 6 years, and now I'm back here. Came back last year, but I'm still going back and forth. So what I'm going to focus on is the health system strengthening that, Nicola, you talked about, because that's, you can have all the innovation, you can have all the technology, but if you don't have the workers there, the healthcare providers trained, or even having, the motivation and that whole culture of work ethics, if that is not built up, then none of these technologies and innovation can be really helpful. So what we have been doing in India as part of should talk a little bit about here, Bill and Melinda Gates Foundation, who went to India more than 10 years ago and then took this, the 2 states, UP and Bihar, UP and Bihar, as you all know here, are basically the United States. It's 320 million people. And decided to, okay, let's work on strengthening the health systems in these two states, working with the central government, working with the state governments. And Pronto International is one of the players in this whole big ecosystem of partners who are working in these states to reduce the maternal mortality rate, infant mortality rate, and increase all the health indicators. So what Pronto does in this case is talking about innovation, now taking innovation down to the health system strengthening here. We actually use we basically build the capacity of the healthcare providers there, right? The local capacity, so that even when all the NGOs of the world leave Bihar or get out of Bihar or get out of UP, the competency stays within the system, right? So that's the whole idea, because we are not there for eternity. And so in terms of innovation, what we do is we actually use simulation here. And the reason I bring this up is because in most countries, you'll see in the US and all the Western world, people use simulation to train their healthcare providers in this case. And these are big, sophisticated simulation labs where you simulate different medical conditions, and you will train the nurses, the doctors, paramedics on how to handle complications and emergencies. But in India, what we did is we took this and created really, really low-tech simulation tools so that you can go and take these tools right down to a sub-center, which is in a small village or a small community, so that you're going to go meet these healthcare providers right where they are, rather than bringing them all to a big simulation lab and training. Then you could only train a few of those. So we have this very basic, low-tech, highly realistic though, simulation toolkit, which is basically you can carry in a backpack. And we take it down all the way to primary health centers, sub-centers, where we can then train the healthcare providers, who are mostly, in this case, ANMs, which is auxiliary nurse midwives. They don't even have, in India so far, they didn't even have a 4-year nursing degree. They had 2-year after high school. That's changing now, but I'm talking about 10 years ago. And so you could train them. So these were the ANMs who, at the primary healthcare centers, there are hardly any doctors. And I'm talking mostly about Bihar and UP. I'm not talking about other states which are, have a better healthcare system. So there are no doctors there. So these ANMs are the ones who are handling all the possible complications that may come in. And mind you that if there is, and let's focus on the maternal health here, because that's what we focus on. If there is a maternal emergency, for these women to go from some remote village to a higher level facility, tertiary facilities, it's very hard. The ambulances are not there, or the roads are not good. So what we have done is we have trained these healthcare providers to, first of all, identify, which was also a big challenge. They could not identify what complications might show up. So identify, anticipate those, and then be able to manage those. And that has made a huge difference in the villages in Bihar, where the maternity mortality rate has really gone down, and the referrals, because otherwise they would just refer anytime they see a little bit of complication, postpartum hemorrhage happening. They're so nervous because they're not trained, they would just refer the women to a higher facility, which would mean many of them would die on the way there. So with taking this innovation of simulation, very simple, making it very basic and available to women or to healthcare providers at the basic primary healthcare facility, it's basically a good example of how innovations can be done at a level where they are needed, right? So that's what we have been doing, and it has really worked very well in UP and Bihar, and we are also expanding it to other states. The other thing I would talk about here is one of the big factors in this building the core capacities of these healthcare providers. It's, clinical skills, yes, absolutely. You need the clinical skills, which are lacking big time. But the other big thing which we have seen is this changing their behavior or the work culture or the motivation. So many of these nurses who work in these facilities have very, because there are also such hierarchies in the system, it's very hard for them to really be fully motivated and fully give it their best, because it's always like, oh, there are so many, we have this, it's become the norm for them that, okay, women are going to die on the way to the higher facilities, so it's okay, it happens, right? But changing that culture, changing that behavior, I think is very, very key. It's more key, I feel, than even improving the, the clinical capacities. Of course, you can change the infrastructure, you can provide more resources, you can make them clinically trained, but unless you change this behavior of how they're feeling and the motivation that they need to do their best, and building that empathy for the women who come to these public health facilities, because most of the women who come to these public health facilities are, of course, the poorest of the poor. They're not, literate. There are other issues such as, we have religious issues, we have, caste system. And so for the healthcare providers to feel empathetic towards these women is what another, kind of innovation that we are building in our training modules, right? So it's basically using persuasive technologies, I would say here. So because it's not that you will treat the woman with respect. That doesn't work, right? That's saying, you can put down these things, okay, thou shalt do that, thou shalt do that. But that doesn't how it works. So basically you have to use these different techniques, persuasive techniques, where they feel that, okay, this is how they must work with the women, or how they feel empathetic towards them. And so for that, what we have been doing is we have been using digital innovation here, right? So we use digital technologies to create different modules. Actually, we have come up with a whole digital comic module. It's called the Super Divya module, we call it, because it's the life in a day in the life of a nurse facilitator, right? A nurse who works at a primary healthcare facility in a place like Bihar or UP. How do they feel? How do they overcome the challenges that they face every day? Because mind you, it's not an easy life for them. They have to deal with lack of resources, lack of infrastructure. They travel 1 to 2 hours every day one way to come to the facilities, and then they have to deal with the hierarchies in the system where they cannot question their superiors, where they cannot question the doctor who will never show up on the site, although they are assigned, they're supposed to be there, but they're never there because they have their own private facilities on the side. So for these nurses, empowering them and bringing them to a point where they can, first of all, feel that they are smart enough, capable enough to handle any kind of complications or emergencies. And how do you do that? How do you build this self-compassion also? So we are taking all of those qualities that you need, that people call soft skills, but we call them very hard skills, but they're really hard to build and hard to maintain. And so how do you build them so that when a woman comes to deliver a baby in your own facility, how can you treat her with respect? How can you treat her with empathy? And how can you make it easy for her and for her family members, making sure that whatever is available in your facilities or whatever can be made available, that you can go, question the authority or ask the authorities to build your facilities like that. So we have built this whole digital module of 10 comic series called Super Divya, which not trains them, but basically talks to them. And it has characters like which they look at when they see these modules, they are like, oh, I want to be like Super Divya, because that's exactly what I face every day, and you have portrayed it exactly like that. And then we have the different ways of how can you overcome those things? How can you make yourself more competent and more compassionate and more empathic? So we are actually bringing in all of these skills, which not many people talk about, but they're so core and so important to how your systems will actually work, right?
So in the interest of time, what I would do is, if you could wrap up, what I'll do is I'll ask a couple of questions, and I want enough time for the audience too, because I think some of that will come up in those questions. Please.
Sure. So I think I can wrap up right here. All I want to say is that this whole technology and innovation are the enablers, and not, they're the means to an end kind of thing, to how can you build the local capacity of the healthcare providers to achieve the healthcare goals that we all want.
Wonderful. It's remarkable. On the panel, we have a US perspective working with the global sort of innovation community and so on. We have a global health view, which has a global architecture, but works in each of these countries, including in India, of course. And then we have on-the-ground view from somebody who's working with a nonprofit with last mile of health workers. So we're really full complement of views here. The session is about redefining healthcare. So I'm going to ask a two-part question, and please take no more than 2 minutes to respond to them. I deliberately want to pack it in 2 minutes so that you're very precise about what your views are on this. And then I would like to open it up to the audience. More conversation we have, more engagement we have, the better it is. So, healthcare system, the way we see it, it hasn't worked. During the pandemic, everywhere, whether it's Italy, US, other parts of the world, India as well. So clearly, this system doesn't really function the way it's supposed to, and there's a lot of inequity and so on. If you were to reimagine, you completely from blank piece of paper, reimagine the healthcare system in India, and India as a proxy of LMIC regions, what would that look like? And what would be the first thing, the most important thing that you would do to go in that direction? So I'll start with you, Stephen.
So I'm going to steal someone's answer, I think. A gentleman named Arvind Kasturia has a wonderful article in the Indian Journal of Community Medicine a couple years back called The Challenges to Healthcare in India, the 5 A's. And he posits that India has to solve for 5 challenges. 1, awareness, increasing individual knowledge of best practices for public health. A wonderful number of examples, like in a study of Haryani found that only 11% of adolescent girls had deep knowledge of reproductive health issues. And it's just, that should be the first order, is a societal effort to increase broad awareness of best practices for individual health. Then dealing with the access question, sufficient access to medicines and public health infrastructure. Perhaps the biggest challenge right now is that 75% of India's healthcare infrastructure is located in the cities, where only 27% of the population resides. And thus, as many as 73% of India's population lacks access to basic medical facilities. So I think dealing with this urban-rural divide, especially by using many of these technologies and solutions we've talked about here to bring innovative solutions into rural areas cost-effectively, will be critical to solving that challenge. Adequacy, as discussed, of medical health care personnel to serve India's society. It's estimated that India by 2035 will face a shortage of over 2 million doctors, even though already it only has one doctor for 11,000 citizens, as opposed to the WHO recommendation of 1 to 1,000. Affordability, over 30% of India's population currently lacks any financial protection for healthcare whatsoever, and accountability, ensuring that the expected standards of service are delivered. So I think about the 5 A's of public health for India.
Got it. That's excellent. Nikolai, what's your vision for healthcare?
I don't have that quote or that paper, but I would say from my obviously it's a big question, and in 2 minutes we cannot answer that. But there is also the state system of India, of course, the very independent run states with different healthcare systems, different investments, and so on. But I think the government, as I've learned, they are taking a lot of steps in the right direction in strengthening the health system, talking about the healthcare workers, allocating more GDP towards human capital projects, education, and healthcare. So I think a lot of the right things are happening right now. I think obviously the equity piece is a big piece in India. I think how do you lift everyone up to the same standard, or actually closing the gap between also the service expectation and quality of care between a private provider and a public provider. I think that's an interesting to actually view that gap shrinking for the future due to investments in the public health systems as well. Across those different pieces of health system strengthening that I talked about earlier. I think that's going to be what I'm going to be watching. How is that equity improving across the country and in the different states, and how do you compare the states to each other so that you lift the whole nation up?
That's a great answer. Seema.
Mine works. So. Yeah, I mean, India is it's a big challenge for India, and we all know with the number of people we have and how they're distributed. But I think what the government, as we heard, government has already taken a lot of initiatives, and I think this health and wellness centers, the Ayushman Bharat project is fairly good. I think, you need something like that, which is all over India in smaller centers also, and it's not just healthcare, as in sick care, as you were talking about, but it's wellness.
Yeah.
So I think something like that is, it's very crucial for India, and I think they're building on that. The other thing I would focus on is the healthcare staff working, right? So having more doctors and somehow incentivizing them to stay in smaller areas, which is where we lack big time, the doctors not being there. And also, training of the nurses, any healthcare providers, the doctors and nurses, not just for clinical, but also the other, other aspects. For example, I don't know if you know, but Piramal Foundation in India right now is conducting a lot of this trainings based on their Gandhi Fellowship program in the middle level of government, all the middle managers. So something like that, I think for all the entire healthcare staff, healthcare providers, as well as other support staff would be very important in India. And then, of course, the infrastructure and all that stuff. So
that's excellent. Yeah. I think let's end the panel here. What I heard was, we need, so a lot of things that are happening today in India are moving in the right direction. We just need to sort of accelerate them, training of people, building of infrastructure, and innovation, including financial innovation. We can take 2 questions.
Let's do it during the break, please. Thank you. So thanks a lot. Let's do the questions during the break. I think you'll have time to intermingle at that point in time. Thanks a lot, because we have to restart at 11. So let's have a quick break. But thank you, Anurag. Thank you, Steve. Thank you, Nikolai. Thanks, Seema, for really joining this panel. Such a pleasure. Thank you.